Dear doctors, hope you all are fine and safe during this COVID pandemic. Myself, Dr. Vijay Krishnan, ENT surgeon from Madras ENT Research Foundation, Chennai. I would like to welcome you all for this live webinar session on pediatric OSAS. This session is going to be a power-packed discussion on various aspects of a snoring child. So I am going to brief about the importance of snoring in a child and how it is different from an adult OSAS patient and how do we evaluate them. Here we have our colleagues Dr. Srinivas Kishore, ENT surgeon from Hyderabad, and Dr. Roshan Ryan, Pediatrician from Chennai, to discuss on various aspects of a snoring child.
Everyone, this is Dr. Srinivas Kishore, ENT and sleep apnea surgeons from Star Hospitals, Hyderabad. At the outset, let me welcome you to this fantastic crosstalk between ENTs and pediatricians on one of the most important topics that both of our specialties deal with today, pediatric obstructive sleep apnea. In this webinar, we would deal with the various manifestations, the clinical presentations and the management of this very cunning disease, which is pediatric obstructive sleep apnea. We will be as clinical as possible so that it will help us in day-to-day practice. So please join us.
Hello friends, this is Dr. Roshan Ryan from Chennai. I am going to enlighten you on 26th at 10 AM on the topic of pediatric OSAS from a pediatric dentist perspective. This is a very common problem seen in this generation of children. So, from a pediatric dentist perspective, how we see this problem and how we clinically manage this problem and how we can holistically help you and the ENT and my fellow medical fraternities from this perspective will be my topic of choice for tomorrow. Thank you, stay tuned.
This is Sivan Pushparaj. I extend my heartiest welcome to you all on behalf of Sun Pharma Pharmacare Division, which deals with Sepodum and Prohance Junior, to the webinar on pediatric OSAs. Today we are privileged to have with us the eminent personalities, Dr. Vijay Krishnan, ENT surgeon from Chennai, Dr. Srinivas Kishore, ENT surgeon from Hyderabad, Dr. Roshan Ryan, pediatric dentist from Chennai. I wish to introduce the young and dynamic Dr. Vijay Kumar, pediatrician and neonatologist from Prashant Hospital, Chennai. He would moderate this session and will act as a bridge between you and the honorable speakers. Once again, a warm welcome to you all, and I thank each one of you for taking time out and being here on a Sunday morning. Once again, this is Sivan Pushparaj, RM Pharmacare Division of Sun Pharma, which deals with Sepodum, digs deeper, Prohance Junior, and all-round nutritional formula for growing children.
Over to Dr.
Can you hear the sound?
Yeah.
Yes, you heard it right. It's the noise of snoring. With this, I stop here, and to discuss on the importance of stopping the snoring, I hand over the session to our moderator, Dr. Vijay Kumar. Thank you. Sir, over to you, sir.
Thank you. Thank you, Mr. Sivan. Just very good morning to all. I'm Dr. Vijay Kumar, pediatrician and neonatologist from Prashant Hospital, Chennai. So today we are just having a more important topic, current trend in pediatric obstructive sleep apnea syndrome. So this is more important thing what we are just going through. There are a lot of issues which is happening because of this. We have three eminent speakers regarding this, the pioneers in sleep apnea, whatever they are dealing with. We have three eminent speakers, as Sivan told. We are just going to have their discussions one by one, and we need to just have your question and answer session in the last anyway. So just coming to the first topic, whether we need to ignore snoring or not in the sleeping children or anything else. Dr. Vijay Krishnan is going to speak. He is the head of Department Snoring and Sleep Disorder, Madras ENT Research Foundation, Chennai. He is the founder secretary of Association of Surgeons for Sleep Apnea and Indian Academy of Otolaryngology, Head and Neck Surgery. He is one of the scientific advisory committee member of Old Sleep Society. He has demonstrated various surgical procedures for OSAS in many national and international live surgical and cadaveric workshops. He has many publications in major national and international journals, has presented papers, and has been invited faculty in several national and international conferences also. And he's an editorial board for various international journals. Sleep apnea, definitely it is going to have impact in the adults, but in a child, definitely there are certain changes, or it is different from adult sleep apnea, and it has a lot of impact in growth, behavioral disorders, and it can have some babysitting or some more educational thing. It may be whatever it may be, it can just have an impact in the growing children. So first thing, we just over to Dr. Vijay Krishnan about whether we want to ignore sleeping children with the snoring. So over to Dr. Vijay Krishnan. He'll take over. Welcome, sir.
Thank you for your kind words, Dr. Vijay Kumar. I think, can you see my screen?
Yeah, it's visible, sir. You can proceed.
At the outset, I would like to thank Sun Pharma Pharmacare Division, especially Mr. Mahendra Varman, Mr. Ranjit, and Mr. Shivant, who has done an enormous support for organizing these kind of academic events in this pandemic situation. Without wasting further time, let me get into the topic, today's topic, hot topic on pediatric OSAS. My topic for discussion today is, should we ignore a snoring child and how it is going to impact its life? So we all know obstructive sleep apnea is a common disease of both adult and pediatric age group patients with myriad of presentation. It is a spectrum of disorder. It is a metabolic syndrome. It can be just a primary snoring, or it could be a severe OSAS, which has to be assessed at the earliest stage as possible, and we should treat at the earliest. So no presentation or lecture is complete without spelling Charles Dickens. In 1837, Charles Dickens characterized this pediatric OSAS in a servant of his friend Mr. Waddell's Joe as like a boy sitting with a fat and red-faced in a state of somnolency in his posthumous paper of Pickwickian Club. Almost after 7 decades later, it was described later. Professor Guy from Amsterdam in 1888 was describing about a character called aproxexia, which is an abnormal inability to pay attention by near incomplete indifference to everything in patients with acute and chronic nasal affection. Especially he is pointing towards adenotonsillar hypertrophy, which is causing hypoxia, which is causing aproxexia. So later, as I told you, after 7 decades, Sir William Osler used this term Pickwickian to describe hypersomnolency and morbid obese patients. Later, after 5 decades, in 1956, Bickelman and his colleagues described and popularized this term Pickwickian syndrome almost after 1 century. So in 1965, Menash and Associates described 2 non-obese children with adenotonsillar hypertrophy and cardiovascular changes which were happening for because of this obstructive sleep apnea, and has been treated successfully with adenotonsillectomy. In the modern medical literature, Christian Guilleminal reported the first series of children with OSA in 1976. Later, after 4 years, Professor Colin Sullivan, when he applied CPAP, in his first series of 5 patients, 1 patient was a pediatric age group. That clearly tells how important and recognized problem of this pediatric OSA more than centuries. So just to give an intro, what is pediatric OSA? It is cessation of airflow at the nostril and mouth for at least 2 breaths in the presence of continuous breathing effort. Hypopnea and apnea, this is what we are talking about. So apnea is cessation of complete airflow. Hypopnea is reduction in tidal volume. It is 50% reduction of airflow associated with either arousal or less than or more than or equal to 3% desaturation in the presence of continuous respiratory effort. That is more important. So apnea hypopnea index is number of apneas and hypopneas per hour of sleep. So what is pediatric sleep disorder breathing? We characterize it as 3 different types of apnea, like obstructive sleep apnea. There is no airflow, but the respiratory effort is present. In central apnea, no airflow, no respiratory effort. As you can clearly see in this picture, there is no airflow, no effort. In mixed, it starts as central apnea, there is no effort. Later, it becomes an obstructive apnea. So that is a mixed apnea. It is considered as obstructive apnea. It is the classification of respiratory events in children is described by Katz and Mockers to define the severity of OSAS. If the age is less than 1, it is considered normal. In an adult, age up to 5 is considered as normal. Between 1 to 4 is considered mild OSA. That means in an hour of sleep, if a child has complete apnea, about 1 to 4 apneas in 1 hour of sleep is considered mild OSA. If the apnea is about 5 to 10, it is considered as moderate OSA. And if the apnea is more than, apnea-hypopnea index is more than 10, it is considered as severe OSAS. It is very common, especially the primary snoring is very common in pediatric age group. It is almost 10 to 12% of children suffer from primary snoring. OSA is 1 to 3% in general population, but it is underdiagnosed, as most commonly this is being ignored. The recent literature says it can be up to 6%. The peak incidence is in the preschoolers because the tonsils and adenoids are slightly larger in relation to the upper airway in this age group. Especially the risk of OSA increases by 12% for each increase of 1 kilogram per meter square of BMI in this age group of children, and 20 to 30% of children with snoring have OSAS, which is quite a significant number. If you look into the cause of the sleep apnea, as I told you, adenotonsillar hypertrophy, other than that, the genetics plays a major role, especially the child with obesity, with the malformed upper airway anatomy, and the relation of the cranial base, that is the skull base, and the angle between the nose and the skull base, and the retroposition maxilla and mandible, the tongue and the lateral pharyngeal wall volume, and even the ventilatory drive and its response to hypoxia, all are being tuned by the gene. Especially the epsilon 4 allele of the apolipoprotein E gene plays a major role in obesity. So what happens when a child have a OSA? It is because of decreased caliber of the airway, which is caused by the nasal obstruction. We all know children are obligate nasal breather, and these excessively compliant hyperplastic pharyngeal or laryngeal soft tissue causes the airway to collapse much easier than in an adult. And because of this compromised skeletal anatomy, further worsen the situation. And neuromuscular compromise and complicated by diminished muscle tone, all this typically causes sleep apnea in this age group. So I'm not going to go in detail about the physiology behind, physics behind this airway obstruction, but stalling resistor model clearly explains how the airway gets collapsed when there is an increased resistance. Nasal, as I told you, the nasal resistance plays a major role in pediatric OSAS when it is compared with an adult patient. The increased upper airway resistance is evident by the improvement in OSA in populations after nasal corrections like sternoctomy or a septal repair or administration of intranasal corticosteroids or any procedures which addresses this nasal resistance will improve the snoring and obstructive sleep apnea in this age group. This will be discussed in detail by Dr. Roshan and Dr. Srinivas Kishore. As I told you, the contribution of skeletal abnormality like hypoplastic maxilla and mandible also plays a major role in this age group. So mouth breathing children habitually lower their mandible, and that influences the dentoalveolar morphology, which results high arched palate because of lack of tongue thrush and narrow max. Because of that, the maxilla growth reduces. That becomes a narrow maxilla and causes retrognathia and increased lower facial height, that is called long face syndrome. And finally, the child lands up like a pinched nostril with adenoid faces. So there are, according with all these data, we classify pediatric OSAs into 3 distinct types. Type 1 is patients with marked lymphoadenoid hypertrophy in the absence of obesity. Type 2 is mainly obesity with mild upper airway lymphoadenoid hyperplasia. And type 3 is children with a variety of craniofacial and neuromuscular disorders. This picture clearly shows you how the adenoids and tonsils is blocking the airway with the typical adenoid faces. And this is in type 2 child with morbid obesity with the mild lymphoadenoid hyperplasia. And these are syndromic children with OSA. So the common symptoms and findings similar to both type 1 and type 2 is snoring. At least 3 nights per week, they will be snoring, and there will be an agitated or disturbed sleep with frequent awakenings. That is the important symptom which has a disturbed sleep. And diaphoresis, night terrors and nightmares, they cry at middle of night. Bedwetting is very common, nocturnal enuresis, and breathing passes, that is choking, that is apnea, which has to be seen during middle of the night. Especially during REM phase of the sleep when the muscle tone reduces. And when the child has increased nasal resistance or adenoidal hypertrophy, the speech will be a nasal tone with a stuffy nose, a mouth breathing with the limited nasal airflow. All these are very classical symptoms and findings which we can see in these both age groups. So if you compare type 1 and type 2, the type 1, as I told you, it's because of lymphoadenoid hypertrophy, which has hyperactive behavior. Contradictory in type 2, where the child is obese, there won't be much hyperactive behavior. They will be dull. In attention problem, there will be, it is more in type 1 patients, and it's okay or average in type 2 patient. All this obesity, enlarged neck circumference, are very common in type 2 children. And all these metabolic signs like depression, low self-esteem, shyness, left ventricular hypertrophy, systemic issues, systemic hypertension, insulin resistance, serum lipid abnormality, elevated C-reactive protein, all these are common with type 2 OSA, that is without lymphoadenoid hypertrophy and obese children which is having OSA. And as I told you, obesity and OSAS plays a exchanging complex mechanism. It's a feedback. Obesity causes OSAS and OSAS causes obesity. So it is very important to treat obesity at the earliest to treat OSA. Why we should not ignore snoring? Because it causes long-term sequelae, growth failure. The child has to resist against this breathing. So the breathing workout increases, that causes growth failure. And disturbed sleep is one of the major cause for growth failure. Reduced insulin-like growth factor causes deficiency, because during sleep, we all know during sleep the child grows. So when there is a disturbed sleep, the pituitary gets disturbed and the growth gets disturbed. And there is a cardiovascular consequence like pulmonary hypertension, especially idiopathic pulmonary hypertension is very common in this, which we think as idiopathic is commonly associated with OSA because of the hypoxia and hypercapnia, which is happening because of obstructive sleep apnea. Systemic hypertension is also common in the pediatric age group, which is caused by the increased catecholamines, which is released during these kind of apneic events at night. The most important thing for which the parents will bring you is low IQ and poor scholastic performance. In the school, they will be very dull. They will be not active, or if they may be hyperactive, behavioral problems, aggressive attitude, poor attention. All this can be attributed to single entity, which is called obstructive sleep apnea. So, as I told you, you can see the child is having mild hear that noise. I'm sure this is actually taken when is the you see wardrobe where you can listen entire noise around, and in spite of that, the child is sleeping because of the disturbed sleep at night. So the common signs, as I told you, are high arched palate and failure to thrive with crowded teeth. These are the typical adenoid faces we see in our children in these patients with OSA. Underdeveloped thin nostril, short upper lip, prominent upper teeth with crowded teeth, narrow upper alveolus, high arched palate, hypoplastic maxilla. All this can be attributed to single thing, which is mouth breathing, which is because of adenoid tonsillar hypertrophy. There are certain questionnaires which we commonly discuss with the parents, like Upper Sleepiness Scale, especially designed for children. Upper Sleepiness Scale is such a scale which is commonly used in adult, where there is little modification done. Here, the sitting and reading, whether if the child is sleeping or not, or while watching television, or sitting inactive in a public place, or as a passenger in a car for an hour without a break, lying down to rest in the afternoon when circumstances permit, or sitting and talking to someone, or sitting quietly after lunch, or doing homework or taking a test whether the child is sleeping off. So with that, we can categorize how severe the child is suffering from. Accordingly, we can expedite the treatment. So complete physical examination, ENT examination, is very important in these children. And we also have to assess the breathing pattern and the quality of speech. Neuromuscular examination cannot be excluded, and it is very important to assess the cranial function and assess the motor control and the coordination of swallowing and phonation and respiration also. And also we have to assess any other craniofacial syndromes associated in these children. So tonsil is very common. As I told you, adenotonsillar hypertrophy is very common, which we can see with tonsillar hypertrophy, which is causing obstruction. So after the clinical examination, we want to know whether the child needs further evaluation or how we are going to manage. So we want to know two aspects of these patients. One is anatomical level of obstruction, and the other thing is how the child is got affected because of this issue. That is a physiological aspect of this problem. So the level 1 PSG is a gold standard investigation in these children. Whether it differentiates obstructive from central sleep apnea, and also evaluates the severity and also identify other sleep disorders. The anatomical level of obstruction can be simply diagnosed with an office-based procedure like endoscopy, fiber optic nasal endoscopy, to look into the nose, whether the child is having any adrenal hypertrophy or turbinate hypertrophy, or is there any other nasopharyngeal mass or polyp that can be easily identified. And simple X-rays like X-ray nasopharynx or cephalometry will tell us about the structures which are behind in the nasopharynx. And then the drug-induced sleep endoscopy gives an idea about what is happening during sleep. So basically, we want to know how much is the static obstruction and the dynamic obstruction which is happening in these children when the child is awake and when the child is during sleep. So most of the time, the static and dynamic obstruction exist together. Here you can see in the diagnostic nasal endoscopy, the huge adenoids which is obstructing, and there you can see a dark space here which is actually the passage for breathing. So these can be identified with an endoscope, or you can take a simple X-ray nasopharynx and you can see and grade it. And more than grade 3 is quite significant and may need further treatment. So PSG, as I told you, is used to diagnose or rule out other types of sleep disorders. It objectively records the sleep stages and the respiratory events. And it's especially helpful in identify sleep disorders like narcolepsy, periodic limb movement disorder, etc. If you ask me, when should we do polysomnogram in a child? There is a humpty number of indications, like if you suspect central apnea, periodic breathing or central hyperventilation syndrome, or sleep disorders, chronic lung disease, when the patient is on CPAP, or if the child is on tracheostomy before decannulation, when the child complains of excessive daytime sleepiness, or a limb movement disorder, or any other sleep disorders, especially obstructive sleep apnea. So it should be a friendly environment. What we monitor is an EEG, that is electroencephalogram, to identify the sleep stages, along with the electroocculogram and the electrocardiogram, pulse oximetry to identify the oxygen level, body position, nasal and oral airflow to measure whether the child is having any apnea, and abdominal and chest movement, and to compare with whether the child is having obstructive or central sleep apnea, and leg movement, and we have to measure the child whether the child is having snoring or not. If polysomnogram is not available, simple audio taping or even video taping is accepted. Yes, it is not for adult, but in pediatric age group it is accepted. Or even overnight oximetry or nap polysomnography. Even we may do it in the daytime for a couple of hours to see whether there is any apnea or not. Unattended home polysomnography like level 3 or level 4 studies are also accepted in pediatric age group. The most important other investigation is a capnometry, which is extremely useful in patients with hypoventilation, obstructive hypoventilation, especially in children with the chronic lung disease and those who receive ventilatory support, where we have to measure the end-tidal PCO2. Alternatively, we can measure with a transcutaneous electrode, which warms the skin, thereby arterializing the capillary blood flow. There we can analyze the carbon dioxide level. As I told you, it is very important to recognize in these syndromic children, and if we can treat them, we can reduce a lot of morbidity in these syndromic children. You can clearly see it is an MRI which clearly shows how the airway in a normal child and how it is obstructing in the OSA child. And you can see the palatine tonsil and adenoid, which is blocking the airway. It's a dynamic MRI of a syndromic child. You can see the huge adenoid which is blocking. This is the palate and the tonsil, and the tongue is not collapsing. You can see adequate space behind the tongue, but the adenoid and tonsil is the important cause in these children. And we can also perform a drug-induced sleep endoscopy. You can assess the turbinate, how hypertrophied it is, and also this is basically we are inducing the child to sleep and put the endoscope inside the nose and retropalatal level to see whether the palate is blocking or not, and also to see whether the epiglottis and the larynx, which is whether we are missing out any other causes of snoring like abductor palsy or a laryngeal polyp, etc. So when do we, the proposed criteria is we consider as major and minor, and if there is any one of the 5 major criteria listed out here, or any 3 major and 3 minor criteria should really indicate the presence of OSA, which requires further referral and treatment. In the treatment algorithm, if a child is screened for snoring, if there are symptoms suggestive of OSA, we have to further evaluate the child. If there is no symptoms of or signs of OSA, we have to continuously screen the child. If any of the symptoms suggestive of OSA, we have to evaluate further. So how we are going to evaluate? We are going to assess whether the child is having any complex high risk, or is there any evidence of cardiac or respiratory failure. If any one of these is present, it has to be referred to a specialist, or we have to expedite the evaluation process and management. If there are no such situation, then we have to evaluate with PSG. So PSG, if possible, we can proceed, or else other studies, as I told you, can be considered. And if PSG demonstrate OSA, further evaluation for assessing the obstruction and whether the child needs surgery or further management, which will be discussed by Dr. Srinivas Kishore. If it shows no, further clinical evaluation and treatment as warranted, we have to manage appropriately. So with that, I conclude snoring is unlikely to be normal in a child. When there is a snoring, definitely there is a nasal resistance, increased nasal resistance, which has to be evaluated and treated. And remember, 10 to 20% has, 20 to 30% of snoring child has OSA. The pathological sleep disorder breathing occurs in 10% of the sleep pediatric population. There are important similarities and differences between sleep disorder breathing in adult and children, and it can cause neurobehavioral and cardiac complications, which is reversible when we treat at the earliest. Thank you.
Hello, Vijay, can you hear me?
Yeah.
Yeah, I think
Dr. Vijay Kumar.
yeah, he left the room for some emergency, I think.
No, Karan, yeah, yes.
So I think you will have to do the proceedings.
Yes. So now we have Dr. Srinivas Kishore, who is an eminent ENT surgeon from Star Hospitals, Hyderabad, who is with us, who has not much need introduction in this country. He has traveled a lot across the country and an international speaker who is with us to narrate how we are going to manage a child with snoring. Both, I think he will be explaining on both surgical and non-surgical management of snoring child. Over to Dr. Srinivas Kishore.
I'm sharing my screen, Vijay.
Yeah.
Can you see my screen?
Yes.
Okay. Good morning, everybody. At the outset, let me first thank Dr. Vijay Krishnan, Dr. Roshan, Mr. Mahendra Varman from Sun Pharma, and IAP Chennai for creating such a beautiful platform, which is enabling us to cross-talk between our specialities. Because when we talk about pediatric OSA, us ENTs and you as pediatricians are equally important in the management of these children. So without further ado, let me just go about talking to you all about the management of pediatric OSA. After a beautiful introduction and a very thorough introduction by Dr. Vijay Krishnan, it's now much easier for me to take the ball forward in the management of pediatric OSA. Now, it doesn't really mean that if an ENT surgeon is talking about management of obstructive sleep apnea, we are only talking about Adenotonisllectomy. Even though the AAP, which is the American Academy of Pediatrics, the Indian Academy of Pediatrics, the American Academy of Sleep Apnea, and our own association, Indian Academy of Surgeons for Indian Association of Surgeons for Sleep Apnea, talk as the Adenotonisllectomy to be the main treatment modality in the management of obstructive sleep apnea. There is a significant role for conservative management. Now, when we talk about conservative management of OSA, all of us are nowadays very busy talking about the COVID pandemic, but we've completely forgotten about the other pandemic that is actually terrorizing the whole world today, which is obesity pandemic. And obesity in children is a huge pandemic that you as pediatricians are dealing with on a day-to-day basis. Now, a recent population-based study involving 400 children between 2 and 8, mind you, these are not teenagers, found that the obesity was the most significant risk factor for OSA with an odds ratio of 4.6. And further analysis of the same topic suggested that each unit in the increase of body mass index, there is a 12% risk of obstructive sleep apnea in children. Now, in our own backyard, this is a beautiful paper that's come out of in the Endocrine Journal. So this paper basically did a study of childhood obesity in an affluent school in Hyderabad. And they took 2 parameters to evaluate their children. They actually took children from across the classes, and they basically deciphered that based on the CDC guidelines, which is an American-based guideline, and the IAP guideline, which is released in 2016, which is more based on the WHO guideline. No matter what kind of metric of measure you use, if you really look at the obesity and overweight category, you're looking at very high numbers. And they came out with a lot of inputs into where the pandemic of obesity is in our own neighborhood in India. And this is another table that basically shows us right from 2002 to 2018 across the regions in the country, wherein they showed that 35% of our population is pediatric population is either overweight, and 24% of our children are obese. And we know that OSA increases as BMI increases, and the percentage only keeps going up. So what are the issues here? So when you have an obese child, what are we really looking at? We are looking at an evil mixture of mechanical factors and functional factors. What are the mechanical factors? We all know that there is adenotonsillar hypertrophy, whether it is an obese child or a non-obese child. You have adipose tissue, which is adding into the mix. Restrictive pulmonary impairment because of the distribution of fat on the chest. Decreased FRC leading to more hypoxia and more hypoventilation. Now, if these are all the mechanical factors on one side, on the opposite side, you are dealing with altered neuromuscular functions and increased tissue inflammation, which is an end product of the obstructive sleep apnea and the obesity per se. So when you bring in a complex mix of obesity and OSA together, an array of things are happening. Basically, something like a metabolic syndrome, and also the burden on the cardiovascular system is quite high. Now, when you talk about obesity management, because it is a conservative management, it has been shown that OSA was successfully treated in 80% of the patients who had obesity and OSA together. So the literature basically tells us that if you were to do an adenotonsillectomy on an obese child, the success rate is anywhere between 10 to 40%. When you compare that result with what just slimming down does to these people. So slimming down has brought down the OSA by 80%, whereas an adenotonsillectomy has only brought it down by 40% by very conservative means. So if you really look at an obese child, you should really consider doing a conservative management. But there is a small caveat here. Please remember, use all the questionnaires that Dr. Vijay spoke about before, assess the child. if this child's symptoms or a sleep study is basically suggesting mild or moderate disease, yes, you can wait and go in for a medical management. Because if you take a severe child with severe sleep disease burden and wait for the weight to come down, probably it may be too late for the child. Now, you cannot undermine the role of INCS and Montelukast. It has been shown that children who have adenoids and tonsils, especially with coexisting OSA, they have increased expression of leukotriene receptors 1 and 2 compared to children who do not have OSA. They may just have recurrent tonsillitis. So recurrent tonsillitis children do not have this increased expression of leukotriene. So if you want to try this for a recurrent tonsillitis children, it won't work. But if you have a child with obstructive symptoms, absolutely INCS and Montelukast is a fantastic cocktail to try. Now, it has been published that a dose-dependent reduction in cell proliferation and secretion of cytokines will be there when you use this as a combination. Also, most of you as pediatricians would be also coming across children who are post-adenotonsillectomy with this little bit residual symptoms, and the parent would definitely come to you and say, doctor, an amazing surgery has been done or an amazing procedure has been done on this child, but still there is some amount of residual symptom. So that is where this combination works beautifully, and why it works, I've already told you. Now, another important aspect that we also need to understand is that when we put these children to medical management, and this is a fantastic paper that again came out much earlier, which took into consideration 700 children of mild OSA. Now, again, I keep talking and reiterating the fact that mild and moderate patients can be put through conservative management, but when it comes to severe, it is probably not a smart idea to try medical management. So let's come back to the role of intranasal corticosteroids and oral leukotrienes. When we try this as a management protocol, the minimum duration or the chance that you need to give these medicine to work is a minimum of 12 months. You can't use it for a day or two or at least a week or two and say it has not worked. You have to give a decent chance for these medicines to work. Now, you all are experts. You know the current strategies in the management of pediatric allergic rhinitis, which is a significant comorbidity in the management of obstructive sleep apnea. And allergic rhinitis is a good comorbidity in for OSA. Now, what I would like to bring in is how these conservative management drugs work. So when you talk about intranasal corticosteroids and leukotrienes, there is a very good evidence that to show that intranasal corticosteroids and anti-leukotrienes decrease congestion, thereby increasing the space available for these children to breathe through the nose and thereby reducing the work of breathing. Now, here is a small chart showing you all the different kinds of medications that are out there and their dosages that is recommended for the management of comorbidity of allergic rhinitis with OSA. Now, in spite of all these conservative managements, here is a child in whom adenotonsillectomy has been done. Please pay attention to this child. And now he stopped breathing. And he wakes up. So this kind of cycle happens again and again and again. Now, when you talk about surgical management of obstructive sleep apnea in children, the gold standard even today is adenotonsillectomy. Now, adenoidectomy with or without tonsillectomy is a mainstay in the management of obstructive sleep apnea with an average success rate of 74%. But here I've added another caveat for you here, saying that this success number is for normal children. So when you look at children with severe obstructive sleep apnea, this is the kind of adenoids that we look at. This is the choana, and this is the adenoid tissue, completely blocking the choana. As you can see here, we are using the cublation technology to basically clear off this adenoid tissue, which nowadays has now become the mainstay in the surgical management of obstructive sleep apnea. It's a very fast way to deal with it. And this is an unedited video with the video running at normal speed. So if you look at it in the first few seconds itself with this particular technology, you can actually dissipate the entire tissue, reducing the duration of surgery, which is very important in the pediatric age group, because the less time that you subject the child for the anesthesia and the lesser time you put them through the surgery, the better it is for them. Now, tonsillectomy is also very, very important. Here is a picture. If to look at the tonsils from above, here is a picture that you all normally don't see. This is a picture of an image that is grasped from behind the posterior corner. So, you know, looking back, this is the uvula. These are hypertrophied tonsils. Now, when you have this kind of a huge tonsillar hypertrophy, that little glimpse is the laryngeal inlet. Obviously, you will have to do some kind of an intervention to allow the air to go in. So, this is a child with huge tonsils, almost kissing tonsils. With the mouth gag in place, this is how the tonsils are almost touching each other. And you can actually see with this kind of scenario is there. The kind of work of breathing for these children is very high. And obviously the symptoms would be very high. The idea is with this kind of obstruction, once you clear off see how much space has suddenly come just by removing one side of the tonsil. So you would know that where we are here to where we are now, you can see a huge physical improvement in the space available. Now, slowly, especially from the 2013, 2015 onwards, there is a shift in literature and also our practice as pediatric ENTs from what we now call a subcapsular tonsillectomy or intracapsular tonsillectomy from an extracapsular tonsillectomy. Now, what are the merits of this different technique of subcapsular tonsillectomy, of intracapsular tonsillectomy to a regular tonsillectomy? Now, for us to understand, we need to know why should we have another technique in the first place? Aren't we happy with the extracapsular or regular tonsillectomy? Now, there is a small issue there. As we know that the incidence of adenotonsillar hypertrophy is also increasing, and the disease burden in younger children, especially below the age of 3, is also increasing. Probably because of the coexistence of allergic rhinitis, probably because of, for various reasons. Now, when you are dealing with such young kids, two things become very important. One is safety. So when you talk about safety, you're talking about two things. You're talking about blood loss and you're talking about postoperative pain. And you're talking about maintaining oropharyngeal hygiene in the postoperative period. Now, when you operate these small young children, even a 20-30 ml of blood loss, because the blood volume is so less, is significant. And if you really look at the blood losses that are associated with extracapsular tonsillectomy, it is about secondary hemorrhage rates is what I'm talking about. It's about 4.6%. When you bring in the same kind of analogy to subcapsular tonsillectomy, the percentage is 1.6%. And hence, subcapsular tonsillectomy in the management of obstructive sleep apnea in the younger age group is now gaining a lot of importance. Now, this concept has been studied. This is a meta-analysis from China. This is an analysis that's come out of the American Academy, and this is published. Here is the study, which is a meta-analysis, says, can intracapsular tonsillectomy be an alternative for classical tonsillectomy in the management of obstructive sleep apnea? And they conclude that intracapsular tonsillectomy can effectively reduce postoperative pain and bleeding, which shortens the time required to return to normal life, which is very important. Now, how you deal with it is very different. I mean, whether you want to use a microdebrider to do it, whether you want to do use a coagulator to do it, that is not the point. The point is how much disease burden you would want to reduce for the child and at what cost. That is the most important. When I'm talking about cost, I'm not talking about money, I'm talking about safety. Now, what is intracapsular tonsillectomy? So here is a child with OSA who's about 3 years of age with severe obstructive sleep apnea. So what we do here is, instead of totally removing the tonsil, which is labeled as extracapsular tonsillectomy, we use this particular tool. It is not about the tool, it is the fool behind the tool which is important. So here you basically mark out the anterior pillar, and from the level of the anterior pillar, you go through and through, and we are basically operating below water. That's why you see the bubbles there. So why are we doing that? Because you don't want any kind of collateral damage. So if you see, by this kind of a technique, you are not exposing any of the branches of the tonsillar artery, and hence the postoperative hemorrhage rates and postoperative pain score when compared to regular tonsillectomy are very, very less. Like I said earlier, 4.6% vis-a-vis 1.6%. The pain scores also are significantly less for this kind of tonsillectomy or intracapsular or subcapsular. But the biggest debate for this kind of tonsillectomy comes, what about regrowth? So this is something that we need to discuss with the pediatricians as well as the parent. So you need to be very careful in who you are doing this procedure for. If you are dealing with a child below 3 years, this could be your tool, the technique to go to. If you have a child which is probably much older, but the complaint is only features of obstructive sleep apnea, this could be a technique to go through. Because if you are dealing with an older child, the relative chance of the tonsil regrowing is very less, because by age 12 to 15, naturally the tonsils will regress, and there is no chance of the regrowth of these tissues. The second thing is, if you are dealing with a child in whom you adopted this technique of procedure and you are doing it on the child for safety purposes, because these children don't gargle or this is a syndromic child for whatever reason, there is a chance of regrowth in these children. But this is something that we need to talk to the parent and the pediatrician. But how can you reduce the regrowth? By good medical management, by identifying the comorbidities and treating those comorbidities together. Now, Cochrane, when you talk about Cochrane and adenoidectomy or adenotonsillectomy versus non-surgical management of obstructive sleep apnea. What if you don't do anything and you leave the children as they are? Now, what does that say? Even Cochrane, which does not give positive results for anything, tells us that for non-syndromic children with mild to moderate OSA, they said that we judge the data on quality of life, symptoms, behavior, and adverse events to be moderate quality, and their outcome data is of very high quality. Now, this topic has been beautifully shown by Vijay as to why children with obstructive sleep apnea have failure to grow. That is because of their fragmented slow wave sleep. And this paper from which is published in the 2018 in our pediatric journal basically shows that significant number of children with OSA with concurrent growth failure could benefit from tonsillectomy and adenoidectomy to recover and normalize their growth rate. This is the mother of all studies, which is an RCT, also called the CHAT study, which is published in the prestigious New England Medical Journal. I will not go through all the points, but please go through the salient points. They have compared watchful expectancy to early management, and they have found that 79% resolution of OSA in early tonsillectomy group, along with statistically significant reduction in symptoms and partial assessment of outcome compared to watchful waiting. Now, there's a small, again, rider in this study. What they also found as a primary outcome measure was the behavioral issues didn't change much when they used a questionnaire. Now, there is a lot of study about whether to use that NEPSY questionnaire or not, because this questionnaire has not been validated for obstructive sleep apnea, but that's a debate for another time. So when you talk about watchful waiting should be reserved for particularly mild disease with limited or no symptoms, particularly for older children. Now, when you bring all the data together and put the results are anywhere between 80 to 40%. Why is that? That is primarily because if you do tonsillectomy and adenoidectomy for every children of OSA without evaluating them, you may land up with a poor success rate. Now, I will share some of my studies. Now, this is a watchpad study of a patient about 9 years old with an RDA of 34. I brought it down to 5.6. But if those of you heard Dr. Vijay's talk, you know this is not normal. There is significant disease, resultant disease that is still left. This is not a eureka moment for me. This child still has significant disease burden. This is another child who's a teenager. I've brought down the sleep, OHI from 46 to 4.9. Again, still not normal. And if you bring in literature here and say whether they're obese or non-obese, in severe OSA, if you look at the failed success rates, 20% fail rate, 20, 28, all these, whether it is male or female, if you are an obese child, we have to cut a very sorry figure to the parent. And significant number of pediatric patients have continuous problems. And like adults, you can't put them back on CPAP because on an average, the use of CPAP is about 2%. So if you look at the evaluation as shown by Dr. Vijay Krishnan, this is a drug-induced sleep endoscopy of a residual OSA child. The adenoids have obviously regrown, and if you go down and see, there is a significant obstruction at the level of the tonsils. The tonsils have regrown, and the hypopharynx is obviously causing cross-sectional area is reduced, the palatal level is reduced. These are the kind of children that basically present to us with significant residual disease. Here is another child with Down syndrome, basically adenoidectomy done, but if you see at the level of the palate, there is significant obstruction happening. You'd see that there is no airflow happening at the level of the palate. And you can see the epiglottis is falling forward. There is a global pharyngeal atony that you can see in drug-induced sleep endoscopy for these children. These children, obviously, when you do simple adenotonsillectomy for their sleep apnea, we will fail. Now, what do you do for residual OSA? You can do procedures, especially in syndromic children. This is a child with Bedwick-Wiedemann syndrome. As you all know, these children with significant macroglossia. You can do modifications of UPPP, which are even successful. Now, I would like to bring in one rider here. What is residual OSA? What is laryngeal OSA? Now, when we talk about laryngeal OSA, we need to also understand that all OSA is not adenotonsillar hypertrophy. Now, if you look at this child for whom adenotonsillectomy has been done, and the parent came back and said, this is, the patient has been sedated, and you can see this is stridor. This is definitely not a stertor, and this should not be confused for adenotonsillar hypertrophy causing sleep apnea. Now, even in kids, you have these kind of pictures in very young age group, wherein you see laryngeal OSA, especially in the pretermers, kids with neurological global delays in the neurological presentation. So, there is a condition which is laryngomalacia, but it presents in the slightly older pre-teenage group. That is called occult laryngomalacia. Now, this is a child who was breathing normally. The moment they go into deeper plane of sleep, suddenly the arytenoids fall forward and start causing sleep apnea in these children. And if you do a supraglottoplasty in these children, they do pretty well, and their sleep apnea results are excellent. It is all about identification and evaluation. In spite of all that, here are certain children, and this is a child in whom adenotonsillectomy has been done with significant residual obstructive sleep apnea. Now, why is that? This is because of the high arched palate. So because of sleep-related breathing disorder, there are significant effects on the upper jaw as well as lower jaw. And what initially starts off as a sleep-related breathing disorder becomes an awake breathing disorder, causing, again, a myriad of symptoms and conditions. So nasal airway, the solution for that persistent airway obstruction is rapid maxillary expansion, which my colleague Dr. Roshan is going to speak about. These are certain pictures wherein we've had residual disease post-adenotonsillectomy, and my pediodontist, Dr. Gayatri, who does an amazing job in evaluation and management of these kids. These are actual pictures from my own patients. You can see how beautifully the arch has expanded. The roof of the mouth is the floor of the nose, and we need to understand that. So this is how this all happens. And this is a small flow chart for you as a take home. First thing is you need to understand whether you're dealing with a non-syndromic or a syndromic child. If you're dealing with a non-syndromic child, and if you see based on clinical details and your questionnaires that it is a low-risk patient, you can try conservative management. If it fails, surgical intervention. But if you think it's a high-risk patient, especially children with mucopolysaccharidosis, children with obesity, or a syndromic child, you need to do a DICE or a dynamic MR and just doing an adenotonsillectomy will not be enough in these children. If you have a syndromic child right away, it's a trisomy patient, always do a PSG because it helps you whether there is a coexisting central situation or an hypoventilation syndrome. Then you will have these kind of treatment modalities. But before you put the patient through these treatment modalities, always do a sleep endoscopy. So in conclusion, obstructive sleep apnea is getting more and more significant. We cannot ignore it. Need for a pre-op PSG need to be assessed, like I showed in the chart and how Vijay also showed, that it's very important based on the need for your patient. Please get a polysomnography done. Adenotonsillectomy, even today, in spite of what all I spoke, is effective. Especially in severe OSA patients and special children, you need to be very careful and have what we call as a shared decision making. Bring in the pediatrician, bring in the ENT, bring in the neurologist, bring in the parent, and have what we call a shared decision making for these children, because it's just not doing an adenotonsillectomy. It is the entire gamut of things that come into play. And this is Ralph Waldo Emerson's, and I would always like to end my talks with this, to know even one life has breathed easier because you have lived. That is to have succeeded. And dear colleagues, pediatricians, you matter as primary care warriors. Thank you very much.
Yeah.
Thank you, sir.
Thank you,
That
Dr.
was a wonderful talk. Yeah. You just throw a lot of insight about the medical management of OSA and the surgical also. So in surgical, as a pediatrician, we get a lot of tips about the recent updates, what was going on, and how to avoid the complications and other thing. And the last flow chart just have a wonderful idea for us, so that how to proceed with the obstructive sleep apnea, and we need to convince the patient for both surgical and for the medical management. Thank you. It was a wonderful talk. Next speaker, Dr. Roshan Rayan. Yeah. So we'll just go to the next speaker of the day, Dr. Roshan Rayan. He's a pediatric dentist. He's practicing for last 15 years. He has 11 years of teaching experience. He finished his undergraduation from prestigious Madras Dental College and PG from Meenakshi Ammal Dental College. And he's a topper in the post-graduation. And he is a pioneer of sedation in India and one of the forerunners in India. So he is POS trained graduate in orthodontics. He is an author of the book Child Dental Health Diary that speaks about small issues of dental issues related to the children, and it's a wonderful guide for the parents also. His practice and lot of focus on interceptive orthodontics, pediatric OSA, and he works in close connect with ENT surgeon and sleep physician in this regard. And he's a wonderful person to just talk about OSA dental issues regarding this in this topic today. So over to Dr. Roshan Ray. You can just proceed.
Good morning, one and all. Am I audible for everybody?
Yeah, it's audible. Yeah. You can proceed.
Thank you, Dr. Vijay Kumar, for this wonderful introduction. And a very big thanks to the eminent speakers who have been with me on this platform on pediatric OSAS, Dr. Srinivas Kishore and Dr. Vijay Krishnan. With Vijay Krishnan, I have been working with him for the past 5 years in close connect on pediatric OSAS. And a big round of thank you to the Sun Pharma for giving this platform to crosstalk with the pediatricians on this topic of pediatric OSAS. So the target audience for today is mainly the pediatricians and postgraduates in pediatrics. And the outline of my topic will be a note on the prevalence of pediatric OSAS, the dental findings in a pediatric OSA, which Dr. Vijay Krishnan talked about, but I'm going to give you some pictures on how to identify it on a clinical basis, and a note on residual OSA from a dentist perspective, from a periodontist perspective, how we look into this problem of residual OSA. Some journals will discuss a few clinical cases on how these results come up after we treat it and deal with it, and a touch on adolescent OSAs, wherein a minor surgical procedure which we can do on the skeletal aspect of the maxilla and how the results are brought out, all those things. So to keep the topic engaged with the audience, I usually have a small game called the Master Listener game, wherein the content of the topic at the end, we will give you 3 questions to answer. So these questions will be the answers, will be the important answers that which you take home. And we have the take home message for the day. Actually, Dr. Vijay and Dr. Srinivas was talking about pediatric OSA, which has a 30% prevalence. But when from a dentist perspective, on a private practice, on a clinical day-to-day basis, when we look at this problem, this is alarming. The numbers are really alarming in nature. When we see 10 patients, out of which 6 patients have this problem existing. Normal children, because of the obesity pattern in which children are there, the eating habits which have changed, and sedentary lifestyle. So what are the common dental findings we see? The common dental findings we see are the tongue thrusting, where the tongue swallowing pattern is different, a narrow maxilla, a posterior crossbite, protruded upper front teeth, because of which the teeth are overjet. Overjet means the teeth are in forward position, a short mandible, and a convex facial profile. When I say all these things are already discussed by Dr. Vijay sir, but I'm going to show you what is normal and what is abnormal, so that when you see a child, you will be able to identify, okay, this is a posterior crossbite, this is an anterior crossbite. So I'm going to show you some clinical pictures to identify this problem on a day-to-day basis when you see children. So I just put a small mnemonic for this. It is called TNPPSC. Okay, like how we have Tamil Nadu Public Service Commission. Maybe you can relate it to this, and you can have this mnemonic in mind. TNPPSC, which means tongue thrusting, narrow maxilla, posterior crossbite, protruded upper front teeth, excess overjet, short mandible, and a convex facial profile. Okay. Sometimes, to make a note, there can be underdeveloped maxilla, or a reverse overjet, or a concave profile. It is not, most of the time it is a convex facial profile. Sometimes the reverse can also be there, where the mandible is little forward and the maxilla is little inward, and which is resulting in a concave facial profile. I'll show you pictures of that also in the coming slides to come. Okay, this what you see is the normal bite of a child. Okay, this is a normal centric bite. Okay, in a normal bite, the horizontal overlap between the upper and the lower teeth is only 2 mm. Here you see the horizontal overlap, it's more than 10 mm. This is where you land up with the excessive overjet. This is called as overjet, and because of which you land up with a short mandible. The mandible is not growing forward to the level in which the maxilla is growing. Okay, so this is a typical convex facial profile, short mandible, protruded upper front teeth. These are characteristic findings you see in a pediatric OSAS child. Here you see here, this is a normal bite, wherein a 2 mm of vertical overlap is there. But this is a complete vertical overlap. This is called as deep bite. Deep bite, when the deep bite is there, there is a lot of pressure on the temporomandibular joint, because of which the patient can land up with recurrent middle ear infection or otitis media. Okay, these are some minor issues pertaining to pediatric OSAS. So this is called as deep bite. So normally when we see the overlap is between the upper teeth is in front and the lower teeth is back. Here you see the upper teeth is back and the lower teeth is front. This is called as anterior crossbite. The same situation, when you bite on the back side, the upper teeth overlaps the lower teeth. Here the reverse happens. This is a posterior crossbite. Posterior crossbite indicates the maxilla is narrow, and this is a very classical finding you see in pediatric OSAS children. Okay, this is a very, very classical narrow maxilla you see. Very rarely you see in a clinical scenario. A very common clinical scenario what you see is a hidden posterior crossbite, something like what we call as an edge-to-edge bite. This also indicates there is a posterior crossbite and a narrow maxilla, which we will be able to identify only when we take a study model and check the measurements, and it will be only in millimeters of difference between the upper jaw and the lower jaw. Actually, the upper jaw has to be more and the lower jaw has to be less. It will be in the reverse fashion. The upper jaw will be less and the lower jaw will be more. So for this to diagnose, the study model will be the best option to diagnose a hidden posterior crossbite. And take it from me, hidden posterior crossbites are a common finding you see in a pediatric OSAS children on a regular basis. So this is a classical picture of a hidden posterior crossbite, almost like an edge-to-edge bite, what we call. But when you take a model, we'll be able to analyze that the measurements are less in the upper jaw compared to the lower jaw. And this indicates a narrow maxilla. In this situation, we will be going in for maxillary expansion. And these are the facial profiles, what I talk about. And this is a straight profile. In this straight profile, everything is perfect architecture. The holistic face structure is perfect. There is no issues. But when you come across a facial profile like this, where there's a short mandible, the jaw is little protruded forward, retruded mandible. This is a convex facial profile. Here, the airway space becomes narrower, and because of which the child can land up with the pediatric OSAS problem. This is again a concave facial profile. In concave facial profile, also the maxilla is narrow, and because of which the tongue is not able to position forward. Tongue falls back in sleeping and resulting in OSAS. And out of 10 OSAS kids or children we see, 7 have a convex facial profile and only 2 or 3 have concave facial profile. And this is a lateral cephalogram we normally take to assess the facial profile from a skeletal aspect. And this is a straight profile. The pictures what you see, this is the X-rays what you are seeing now. The same patients what I showed you in the last slide. This is a straight profile, this is a convex profile, and this is a concave profile. The lower jaw is forward. Here the lower jaw is placed back and the upper teeth are actually forward. In this, the teeth are only forward and not the maxilla per se. So as I told you, when we start dealing with OSAS children, what are the investigative tools, what are the records we take are extraoral and intraoral photographs, a lateral cephalogram to assess the airway and the facial profile from a skeletal perspective as well as from the soft tissue perspective. OPG is a full X-ray, panoramic X-ray of the teeth to see how well the teeth are developing. A study model. Study models are the best tool to assess whether the maxilla is narrow or not. And this is the study model we take. And here we analyze the distance between the intermolar distance, what we call. This is the distance what we take, and this is the distance what we take, and we compare. And usually, it's for an average adult child, like 10 to 12 years, is about 50 mm, and for the upper teeth, and for the lower teeth, about 48 to 50, and upper teeth is about 50 to 52. So this will be in the reverse fashion. Okay. So in this situation, it indicates that we need to expand the maxilla. So how do we approach going out and treat issue, taking this problem forward from a dentist perspective? The important question what we put, when was the best time to intervene? If you look at the benefit versus risk ratio, if the risk involved is very high for the child, from the apneic and hypopneic episodes, after the adenotonslectomy is done, still they have problem. We look into it and we can start intervention from the age of 6 years. We look at this problem in 2 perspectives. One is if it's a purely functional problem, or there is a genetic factor in the skeletal expression along with functional problem. Okay, it indicate we normally use a generic term called malocclusion. Malocclusion means it involves all the collective terms, overjet, crossbite, everything comes under the generic term called as malocclusion. Okay, this malocclusion can happen because of genetic reasons also, and functional reasons also. If it's a purely a functional problem, and this is why the OSA is landing up, then we treat the child by 6 years of age, and we can manage till 11 years or 12 years, but earlier the better. If there is a combination of genetic and functional, there is a skeletal expression also happening, then even though we correct the functional problems and trying to correct the OSA, the jaw keeps expressing. In those situations, the skeletal expression happens till 16 to 18 years. So you need to keep the patient prepared for a 10-year plan. So we start working on these kind of patients with regular follow-ups and from the age of 6 till 16 years to avoid any kind of major surgeries on the maxilla or on the mandible. Coming to residual OSAS, Srinivas sir was very much lot of things he was discussing about residual OSAS. Glad he has enlightened me also about that. I've got a lot of information about this. But from a dentist perspective, how we look at this problem? Most of the time, what the parents land up is, after we send the patient to ENT for adenotonslectomy, they do the procedure and then they come back to me after 3 months or 6 months, they say the problem still exists. What exactly is happening in these kind of situations? First, the patient becomes a pathological mouth breather, and over a point of time, the brain has got tuned to breathe through the mouth even after the adenotonslectomy surgery is done. So it becomes a habitual pattern of breathing. So pathological breathing slowly lands up in a habitual pattern of breathing. If it's a habitual component of mouth breathing, if it is existing, then we will be in a position to address this problem in a very effective and efficient manner. So in these kind of situations, what kind of appliances we give for the patient? This is a classical convex facial profile adenoid faces child with a short upper lip and a hyperactive lower lip and incompetent lips and a convex facial profile. So in these kind of situations, we give something called as a oral screen. This is a kind of a heat cure fabricated acrylic appliance, which is custom made for that particular patient's child mouth. And you can see here some small holes in this. So patients who have been breathing through the mouth for a very long time, suddenly if you put these kind of appliances, they find it very difficult to hold it, especially to wear it in the night. So we give these kind of holes so that they partially breathe through the mouth, and slowly as these get adapted, then we close these holes with acrylic again and they become completely normal nasal breathers. This appliance wear is usually suggested in the night for about 8 hours and evening about 1 hour. Okay. So, and some myofunctional exercises are also given along with it to make them get adapted and to hold the appliance much well, and the muscles also to become holistically better in the facial architecture. So this is an oral screen appliance, and this appliance wear is for about 6 to 9 months. This is also another myobrace, what we call. It's a silicone rubber material we can use to correct if there is abnormal muscle forces which is causing the issue, we can reduce the muscle force and also to correct the mouth breathing and the tongue position, everything. But these are all removable appliances, and these are some snoring devices, the strap which we use for correction of only habitual components. Coming to the narrow maxilla with posterior crossbite, a lot of things have already been discussed. It causes upper airway obstruction, obstructive sleep apnea, and nocturnal enuresis. So you have, whenever there is a narrow maxilla, enlarged tonsils and adenoids, habits like thumb sucking, mouth breathing, we need to rule out. Snoring at night, we look into. This point, I would like to enlighten you at this moment for pediatricians. If the child is a prolonged breastfeeding child, maybe for more than 2.5 years or 3 years of age, or a bottle-fed child, these children are prone to become snoring children at a later age. So when you take a good history, you will come to know these children had been on a prolonged bottle feed or breastfeed. The reason behind this is they are more, the longer the duration of feeding, what happens is they are more into the sucking pattern, and the chewing pattern and the muscular development doesn't happen more, and the orofacial musculature is more flaccid in nature, because of which they are always prolonged eating time. They take a lot of eating time, and they tend to have a short mandible. The mandible growth becomes shortened in nature, and they land up with a convex profile, and because of which secondary OSA starts developing. And all the other functional factors like speech difficulty, evidence of cheek biting you can look into, excessive daytime sleepiness, history of any cleft palate surgery, and nocturnal enuresis. Also at this point, I would like to say that because of the antidiuretic hormone secretion, which requires good amount of oxygen saturation, which doesn't happen in OSAS children, because of which they end up with nocturnal enuresis. And what we can do from a pediatric dentist perspective is we can expand the maxilla, and what actually happens when we expand the maxilla is also I'm going to discuss with you. So a couple of evidence-based discussions on OSAS from a dentist perspective. What we feel is there is a rapid palatal expansion is what we suggest for narrow maxilla, is predominantly recommended in children with maxillary constriction, and is considered always the last treatment of choice in patients with nose breathing, OSAS, nocturnal enuresis, and conductive hearing loss. Different sites of obstruction of the upper airway is also associated with different types of dental malocclusion. This is a very good article by Nunes WR at the Archives of Otolaryngal Head and Neck Surgery, published in 2010. Orthodontic maxillary expansion and its effects on nocturnal enuresis. And they have done a very prospective study. In this, what they done, they found out in 10 children, then they do expansion, about 4 become completely dry after the maxillary expansion which happens. And this is a very good study to say that there is a very close interlink between the narrow maxilla and nocturnal enuresis. And these are all coexisting factors along with pediatric OSAS. RME helps in relieving upper airway obstruction and thereby also ceasing nocturnal enuresis. This is another article by Angle orthodontist. So RPE means rapid palatal expansion, should be considered for airway constriction and nocturnal enuresis when all other treatment modalities have failed. So the evidence-based summary clearly indicates there is a very close relation between malocclusion, upper airway obstruction, nocturnal enuresis, which are key coexisting factors leading to OSAS. So how do we go ahead treating this problem from a dentist perspective? First and foremost, we take a comprehensive ENT evaluation, and either these kind of patients, OSAS patients, are landed up to us by reference through pediatricians, or the patient parent itself brings the child to us saying the teeth is placed forward. But when we take a clear history with them, we come to know that they have OSA, they have a snoring issue, they have bedwetting, or they have upper airway obstruction, recurrent cold and cough infections. So we come to know that actually the teeth are not in forward. These problems are making the teeth coming forward. So actually they are seeing the tip of the iceberg problem and not the real ice inside the water. So in these kind of situations, we take a comprehensive ENT opinion to rule out any upper airway obstruction. If it is there, whatever type of surgeries they have to perform, as Dr. Srinivas sir was discussing and Dr. Vijay was discussing, they go ahead with the surgeries, and then they refer the patient back to us. Also, we take a urologist opinion in case of nocturnal enuresis to rule out any kind of urological pathology. So these some kind of maxillary expansion appliances, these are slow expanders called as a coffin spring, expansion screw, and this is called as a quad helix appliance. These are slow expanders for the narrow maxilla. And this is the classical, commonly used expander, what we call as a HYRAX, hygienic rapid expansion appliance. And this is a small cement we place on top of the upper jaw to relieve the bite of the upper teeth to the lower teeth so that expansion happens very fast and very free. This is another new appliance called the HAS expander. These are all rapid expansion appliances. I repeat, HYRAX is hygienic, it stands for hygienic rapid expansion. And this has a small screw here, and this screw, there is a small key to activate the screw. And each screw activation, you expand the jaw by 0.25 mm, and this has to be done on a daily basis. So how much of expansion going to happen and how much of expansion we need to decide to expand is all, there is a small mathematical calculation, and what exactly happens to the roof, that is the nasal floor, by the expansion of the maxillary roof. So this is a picture to show you the real expansion which happens, and this is the expansion appliance. And this is after the expansion, we give a small retention appliance called the transpalatal arch to hold the maxilla in place so that sufficient bone formation happens at the mid-palatine suture. So what exactly happens? So suppose we are going to plan for expansion of about 5 mm or 4 mm. Suppose we expand 4 mm of maxilla, we consider the nasal cavity as a cylinder because it's a hollow cavity. So if it's a cylinder, the dimensions we are looking at is a length into breadth into height. So we are looking at 4 into 4 into 4. 4 into 4 is 16%. 16 into 4 is 64% of oxygen saturation increase from the existing saturation what is present for the child at that point of time in the sleeping. So that is what we are expecting the result, what is going to happen. That's going to be, even though it's a 4 mm what we are going to talk, the expansion and the result of oxygen saturation what the child is going to get is very much high, and the results are going to be very drastic changes we can expect when you do this kind of maxillary expansion. So a couple of cases I'm going to show you to you right now. So this is a classical convex facial profile OSAS child. So we plan for bringing the mandible forward as well as expanding the maxilla. This appliance what we call as a HYRAX with fixed twin block. And the lower jaw, which has which is so retrographically placed, is brought forward like this after the expansion and bringing the jaw forward. And this is the bite you achieve after the. This is a pre-result and there's a post-result. Pre-op and this is a post-op. And this is another 5.5-year-old child with a characteristic stooping of the craniocervical angulation of the patient. If you see from the facial profile angle, is always placed forward to get the required amount of oxygen for breathing, to keep themselves comfortable. So they always placed a little forward. The neck is, the head is always placed a little forward, and you have a short mandible here. So in this case also we have a fixed twin block with HYRAX placed, and this is the expansion. This is the, and this is after the expansion. And this is the final result. You can see now the facial profile and the stand the posture of the child is better after compared to the pre-op. And this is another child. What the two cases what you saw was convex facial profile. Now I am going to show you a concave facial profile where there is an underdeveloped maxilla but a normal mandible, and how we are going to correct it. This patient had snoring and nocturnal enuresis. This is called as class 3 malocclusion. So you have an anterior crossbite, narrow maxilla, and a normal mandible. In these kind of situations, we take the X-ray, confirm it, and then we plan for, sorry for the poor quality of this picture, and we can for something called as a tandem appliance, where we hold the mandible but bring the maxilla out, and it's a slow expansion device, what we have used here, Fordelix. And this is the result we get after the expansion and bringing the maxilla out. And this is the pre-op, and this is the post-op. And these are some common anti-snoring devices you would have seen and you would have come across. This is a reverse pull headgear to bring the maxilla out. This is just to hold the mandible. This is called a chin cap. And this is to retroposition the device, retroposition the mandible forward, which can be worn during sleep. This is mainly recommended for the adults as a common anti-snoring devices. And I'm going to just touch about a little bit about the adult OSAS and the adolescent OSAS. Adolescent OSAS, that is after 16, if you are looking at expanding the maxilla, it's very difficult to expand the maxilla because the sutures are all completely closed. In these kind of situations, we just give a osteogenetic displacement of the suture. It's called as a surgically assisted rapid palatal expansion. And then we insert the maxillary device, the expansion device, and we expand the maxilla. Okay. So I'm just going to run a video on how this has been done, and also how the device has been placed inside the maxillary expansion device, and how do we activate everything. I'm just going to show you now. It's a crowded teeth, the narrow maxilla. This is a sharp surgery, and this is what you see is the maxillary expansion device, Hyrax appliance being placed. In children, younger children, we only do the expansion. In adolescent children and adults, we plan for rapid palatal expansion, where we cut the sutures and displace the maxilla from the nasal floor, and then we expand the maxilla. And that's the key which is being used to expand the maxilla. And this is how we align the teeth after with braces. This is a live surgery of a surgically assisted rapid palatal expansion, and you can see the braces are also in place, and also inside the patient's mouth you have the maxillary expansion device also. So incision is made, and you use a piezoelectric saw to cut the maxilla for minimum bleeding. And we disengage the maxilla from the nasal floor. As Dr. Srinivas was telling, it's we are on the roof, the maxilla, the dentists work on the roof, and they have the floor, the nasal floor, and we are very closely related. And the mid-palatine suture is also being dislocated. When you dislocate the suture, we are able to expand the maxilla easier in patients who have whose growth has been completed. And I would like to show you another video also of a surgery, small surgery, which is like where the surgery is also done with the you can see the surgery being done, and also the like I want to show you in this video the maxillary expansion device also inside the mouth. So you can see the maxillary expansion device also inside the patient's mouth, and you can see the activation being done. That's how the activation is being done. And looking at this, you might think that it's very difficult to activate, but we teach the parent how to do it, and we make them do it in front of our eyes, and then only we send the patient. And this has to be done as a home therapy by the patient's parents themselves, and the key is given to them, and we really motivate them to do it, and it's possible to be done by them, actually. So every day they need to do a quarter turn expansion, and every turn it expands the maxilla by about 0.25 mm. Suppose we are looking at 4 mm of expansion, so we are looking at about 16 turns. That's for 16 days, and we give a calendar to them, and this calendar they need to mark it up, and they need to bring it back to us, and then we re-evaluate. And usually when we do the expansion, we expand the maxilla extra about 2 mm to compensate for the relapse. And these are maxillomandibular advancement. This is not under my purview. This is completely by the oral and maxillofacial surgeon's purview, just for information purpose. For severe OSAS, for genetic conditions where the skeletal abnormality is so bad, where we cannot achieve good results, then we look at maxillomandibular advancement surgeries. That is also done at the adult stage. And these are distraction osteogenesis devices which are used in syndromic patients who are having a narrow short mandible. In these kind of situations, you use these devices called as the distraction osteogenetic devices. But these devices can be used at a young age itself. From the age of 4 itself, we can start using. These are some intraoral distraction devices. And the take-home message for the day is overjet, e-bite, cross-bite, open bite. All these kind of different bites will impact the holistic ENT architecture. Study models is an important tool for assessment of a narrow maxilla. Evidence-based summary reveals a very close relation between malocclusion, upper airway obstruction, and OSAS. Functional impact of a narrow maxilla, the various factors which causes a narrow maxilla, we have discussed that. Hyrax is the most commonly used appliance for expansion of a narrow maxilla. And the effects of RME on the nasal floor. It causes improved nasal breathing, better oxygen saturation, and increased lymphatic circulation. 6 years will be the ideal age to start intervention, and earlier the better. And last but not the least, whenever we look into an OSAS child, we look into it as from a team perspective. The pediatricians, the ENT surgeons, the pulmonologists, we can also give you a valuable added tool to be with you in traveling, in handling these kind of patients. And when we consider the benefit versus risk, if the risk is very high, definitely we need to look into the benefit of treating the child as early as possible. And the master listener game, we have 3 questions. The ideal age to start intervention from dental issues for a functional OSAS child. Appliance of choice to correct narrow maxilla and posterior crossbite. And the mnemonic for the dental findings of OSAS. These are the 3 questions for the day. You can use the chat box and you can type it up. And that's the thing. And I'm very much happy and humble to be part of this forum to enlighten pediatricians from a pediatric dentist perspective on pediatric OSAS. Thank you. Thank you, one and all.
Thank you, Dr. Roshan. It was a wonderful presentation. You just enlightened what are the dental issues which may be related with OSAS along with Dr. Srinivas and Dr. Vijay also. So it's a wonderful thing. We just came to know what all can be done regarding the dental procedures. It can just come through and we can just go ahead. So it's a good thing. We'll just go ahead. Next, we just go to the question answer session. We'll just go one by one. The first question, I'll just go to the Dr. Vijay. So is the snoring problem at a child has any relationship with childhood bronchial asthma? Is there any relation between bronchial asthma and the snoring? It's by Dr. Mohammed.
Basically, as I told you, when there is a allergic is a common etiology for both the upper and lower airway. If that is going to be the reason, the child can have snoring along with bronchial asthma. But there are so many other causes for snoring. So that doesn't mean that all the patients with snoring will have bronchial asthma, or all the patients with bronchial asthma will have snoring. So definitely, entire is one upper and lower airway which has a common etiopathogenesis of allergy.
Yes, sir. As a pediatrician, we just know not only asthma with the snoring, we have some other symptoms with a cough and other issues also related with it. So you can easily differentiate between bronchial asthma and the snoring. If there is another allergic rhinitis, only nasal block is there. So there won't be any problem with the snoring. The snoring is related only with a nasal block. So it can easily relieve with the nasal drops. It may be a xylometoxylin or a nasal drop. There's a normal saline nasal drops, depends on the age group. So we need to easily differentiate between the snoring and the bronchial asthma, because associated and the bronchial asthma, it's a seasonal changes. So it can come on and off, and it can be just tackled in the thing. The history also give a clue to this. So the next question to Dr. Srinivas from Hemanta, the diagnosis and treatment of laryngomalacia, what are the DDs you can just cite for it?
Thank you, Dr. Vijay Kumar, for that question, and thank you, Dr. Hemant. So the thing is, we need to understand that every stridor in the neonatal age group is not laryngomalacia. That concept should go, even though there are 30% of cases of neonatal stridor is because of laryngomalacia, not all stridor is because of laryngomalacia, number one. Number two, when we talk about laryngomalacia, it is also important to also quantify as to the impact of laryngomalacia on the child. So what is the impact? One, is there failure to thrive? Or two, are there any kind of feeding related issues? Now, if there is failure to thrive, that means there is increased work of breathing because of the lax tissue in the supraglottic area, contributing to the failure to thrive. This child needs to be evaluated and managed accordingly. Number two, the second most common cause of neonatal stridor, as you know, is bilateral vocal cord palsy. Also, why I would like to bring that into this perspective is I've showed a video of a slightly grown-up child, 5-year-old child, who was thought to be having snoring, and adenotonisllectomy was done. Unfortunately, the child had bilateral abductor palsy, congenital abductor palsy. That is a criminal from a clinician's point of view, not being able to differentiate a snoring from stridor. So that onus is onto us. So the third differential diagnosis for stridor that we need to look at, if, that could be causing problems, is a web, a congenital web. The fourth one will be, the third one will be subglottic stenosis. Fourth one will be a web. Fifth one will be a cleft. So these are the differential diagnoses that you need to look at when you're talking about congenital or neonatal stridor.
Thank you, sir. Next question to Dr. Roshan Ray. Dr. Roshan, as a pediatrician, we just come across a lot of nocturnal enuresis cases. That too occurs by 6 years, 7 years. It may be a recent onset or late. As a pediatrician, we do rule out urinary infection related to any urinary issues which is happening. So if it is so, what are the dental problem a pediatrician has to look for, and when we have to refer to this? Because we need to rule out the basic things regarding the nocturnal enuresis, which is a in-between onset. Because for us, syndromic child, it's totally a different picture. We need to just see for a normal child, even at 8 years, 10 years, the parents are coming, still the baby is coming with a bedwetting. So they are clearly disturbed. So as a dental perspective, what you just want to tell to the pediatricians?
Actually, nocturnal enuresis is a very big social problem for the parent. Actually, they cannot even take the child to a outside. They cannot take them to travel in a train. There is so much of social problem they'll be facing actually. So, considering this, it is considered normal till the age of 3 or 4. Okay. So suppose it's going beyond a point and we are still not able to control it. Sometimes, most of the time, this nocturnal enuresis automatically gets corrected by the age of 6 or 7 years, because the maxillary expansion, the transverse growth of the maxilla, 60 to 70% of the growth happens at that age, actually, the anterior maxilla. So that is when the upper teeth starts erupting, the upper permanent teeth starts erupting. So that is when this transverse growth is maximum potential is there. So when the maxillar growth is maximum potential is there, automatically oxygen saturation and the nasal floor, then all of the nose also spreads up in size. So automatically oxygen saturation increases, so it automatically gets corrected. Suppose it is not getting corrected, definitely we need to look into from a dentist perspective. We have to look for posterior crossbite, which I showed you pictures, and we have to look for narrow maxilla. A pediatrician may not be able to find out a hidden posterior crossbite when they clinically evaluate. Only a dentist will be able to find out a hidden posterior crossbite because it is a very, very edge-to-edge bite, and you will not be able to identify it. If it's a very classical posterior crossbite, when you retract the cheek, you'll be able to identify that the lower teeth is outside and the upper teeth is inside. This is why this is the very classical finding. So if it is like that, the upper teeth is inside, then it indicates that the maxilla is collapsed, because of which there is a high possibility the oxygen saturation is not good, because of which the child needs expansion. Okay, so if there are also other secondary factors like cavities and all those things coming up for a child with narrow maxilla, but narrow maxilla has a very close correlation with OSAS and nocturnal edemesis.
Okay, thank you. So next question to Dr. Vijay. How to check clinically whether the child is having a nasal deviation, nasal septal deviation, or when should we refer to the ENT specialist? If from Dr. Siddhi.
From the clinical history itself, the child will say, I am not able to breathe through one side of the nose. That itself will give an idea whether that side is blocked. Sometimes that side, the child may be having a polyp or a turbinate hypertrophy, but that doesn't rule out the other pathologies. But the common condition is the patient will say, I am always not able to breathe through the right side of the nose. Nose means there is a deviation to the right side. And by examination, simple cotton wool test, what we commonly do, just place a cotton wool near the nostril, so the child is not able to blow through that side. And the next thing is cold spatula test. All other clinical examination where we just keep a cold spatula, the air flow may not be good at that side. The other next step is to do an anti-rhinoscopic examination where you just push the columella and the tip of the nostril upwards to see inside whether there is any deviation. These all gives you an idea about the anterior part of the septum, whether it is deviated or not. But if you have to really see how the entire septum is placed and structured, you may have to get an endoscopy inside to see how it is. That is will give a simple idea, but it is little difficult to do in a pediatric age group than an adult. Or a CT scan will help you to assess the entire length of the septum. So clinically, these are the simple tests where we can assess the nasal patency.
As we all know, I think most of us, we have a deviated nasal septum. At what severity you want to intervene, sir, for OSA, anything?
See, usually in pediatric age group, up to the age of skeletal growth, we usually don't intervene unless it is very gross and the child is not able to breathe at all. That is grade 4 or maybe in grade 3. And also if it is going to cause other pathologies like recurrent sinusitis on that side or a polyp or something, some other pathologies caused because of this septal deviation, we will have to intervene by a septoplasty. So otherwise, we don't usually intervene in that age group.
Thank you, sir. Next question to Dr. Srinivas. What is the minimal age for adenotectomy? Just I want to add on to the question. Adenotectomy, when we need to just go for a baby. So what is the severity? We can just go with the OSA, and because most of the time when we counsel for it, even as a ENT surgeon, as a pediatrician, only 50% of the patients turns up. So they are very reluctant to just come for treatment. And how to insist on adenotectomy? We just go.
So I've been actually waiting for this question.
Yeah.
Sir, it totally depends on the impact it is having on the child. Okay, so as primary care physicians, because most of the children come to you first, and you will be taking care of the child right from birth, you will be able to actually see whether the child is sticking to the growth patterns, the growth curve. The moment if you see that the child is not sticking to the growth curves, you see some amount of the percentile is falling down, we have to understand something is not right.
For us, it's easy for a patient to convince for a tonsillectomy. So
Yes.
it's easily visible and the parents are also seeing it. For adenoids, we do have a lot of problem along with you also.
Correct,
because for you also, it's more difficult because the parents are not viewing and we need to just show more evidence for them.
Correct. Because what you see is what you believe.
Yeah.
So what also happens is, these children, what is very important for us is for you also to get a video of these children when they are asleep. If they are portraying certain typical symptoms of mouth breathing with their neck extended, that is clearly going to tell us that there is an adenoid hypertrophy that is causing a problem. And as Dr. Roshan said, if there is some kind of dental malocclusion that is probably happening, but all those happen little later. A video will very clearly tell us what is going on in a very subjective way. And you also as pediatrician would be able to say that, the recurrent otitis media with effusions, child is coming back with recurrent ear infections. The child is probably coming to you with symptoms, or the parent themselves will come to you, so the child is just not able to breathe. It's more often the adenoid than the tonsil, because in that early age group, that means we're talking about months to maybe 3 years or 4 years, it is the adenoid that causes more resistance to the airflow than the tonsil itself. Now, when you and a simple answer to your question is, in fact, if the child is having problems, supposing the child is at trisomy 21, the child is a very frail child or a CP child having significant amount of obstruction to the free flow of air, 8-9 months also we do adenoidectomy to basically, because this work of breathing is associated with the rest of the parameters. See, their physical, their occupational training will suffer, their speech training will suffer, their general global growth will suffer. Hence, we do an adenoidectomy as early as 9 months.
Okay, sir. Fine. And how to explain to the parents, is it important? Another thing we need to just go ahead.
Yes. So basically, I use a lot of educational videos, sir. I use a lot of videos and patient testimonials. These things actually, see, they don't know how much we know. We should understand that. Like how we don't know their subject, they don't know our subject. So the onus is on us as pediatricians, as us ENTs, to educate their parents, to tell them that, look, this is the sequence of events that can happen, and show some pictures as to see this is how the dentition will change. This is how bring in behavioral issues like ADHD. All these things can happen, and if we intervene early, as the literature has shown, we will be able to prevent the child from taking that path wherein there is a point of no return. For example, ADHD and behavioral issues, it has been shown that the earlier you intervene, the better it is for the child, and of course the better it is for the family.
Definitely, sir. As a pediatrician part, we just counsel through the hypoxia to the growing brain. It's less than 2 years or even 2 to 5 years. Between 2 to 5 years or 6 years, only thing, the behavioral disorders, again, post-scholastic performance. Definitely the parents are catchy with that word. So my baby can't do well with this school, and they are sleepiness in the school and other thing. Definitely they are having attention towards that. At least they come and consult and just they go at it.
Absolutely, absolutely. Thank you.
Next to Dr. Roshan, I diagnose a patient with obstructive sleep apnea. I'm just a pediatrician. I'm just seeing one child. I have some symptoms of obesity and other things also. And I suspect some adenotonsillitis also along with it. May I need to just refer to you initially for dental examination, whether it also contribute to this, or I'll directly refer to the ENT surgeon to decide on it?
First will be the ENT surgeon to decide on it. Okay. And even if the patient comes to me and I feel if the patient is a OSAS child, first thing I do is send him to the ENT, send the child to the ENT, get a comprehensive ENT evaluation done, and then take it there from that forward. Okay.
Okay.
So suppose they say, I'm going to give some allergic nasal sprays for the child just to hold on, just to shrink the lymphoid tissue. And then I look into the dental perspective and see what are the problems there. And then I address the problem. The results are much better rather than me taking it forward directly. Okay. So that is how it can work.
Thank you. Dr. Vijay, when we recommend polysomnography for other patients, is it easily available? Because as a pediatrician, we must know, because it's done by us, or you can just take over once we refer the patient, or we can do it by ourselves and you can just send to you.
See, as I told you, level 3 PSG accepted in this age group. So there are many companies which does it as a home study. That will be more comfortable for the child. And if the child need further evaluation, or if you suspect anything clinically which is not correlating with the sleep study report, you can suggest a hospital-based study, because level 1 PSG.
Yes.
So otherwise, level 3 PSG itself sufficient, and definitely that will give you a lot of information for you to grade the severity, the oxygen saturation levels, and oxygen desaturation index, and whether the child is having any central apnea. So there are much more details you can get it with that kind of sleep studies.
Okay. Thank you, sir. We need to just counsel them for polysomnography. Is it a mandatory test before you just manage your treatment, or we need to just have a additional thing to just go with your management?
Practically, we don't do polysomnogram for all the child which is having an OSA. For example, if the clinically we are able to identify the adenotonic hypertrophy, which is a static obstruction, and we are not going to put the child on polysomnogram unless there are other comorbid conditions, or if the child is having a poor scholastic performance and poor growth failure, or syndromic children. So otherwise, we are not routinely suggesting PSG in this age group. But when there is a recurrent obstruction or a recurrent OSA after a surgical intervention, then we would recommend PSG and further evaluation like endoscopy or dynamic MRI to identify the site and the level of obstruction and the severity, so that we can manage how we can manage the recurrence.
Thank you, sir. To Dr. Srinivas, we are just treating a lot of patients with allergic rhinitis also. Sometimes it may be intermittent snoring episodes. It's not a continuous snoring episodes what we just come across. It may be related to the allergic tendency what the baby has. We do treat with medical management with the sprays and levocetirizine, montelukast and other things. Okay, how long we can wait with this? Because it's a seasonal variation. It's happening throughout the thing. It happens most of the November to December or January time, and again the baby becomes normal and it have a normal life. Again in between it was aggravated. So how much this babies has to be treated, till what age, and when your intervention come just for evaluation and further management, we can just refer to you.
So, sir, as pediatricians, you would already know that there is a allergic rhinitis as a comorbidity to the already existing sleep apnea.
Yeah.
So the thing is, it should again depend on how much deterioration of symptoms are we really seeing with this association. Are we seeing a rapid deterioration wherein the parent is actually seeing that there is a stoppage of breath, or the child is, or you're seeing a significant a decrease in scholastic performance during those months, or are you seeing a significant deterioration in the overall symptoms of this child? If the child is already having obstructive sleep apnea and this super added allergic rhinitis is causing significant deterioration in the quality of life of this particular child, then probably medical management will not work. But if there are mild symptoms and this is only intermittent allergic rhinitis, not persistent allergic rhinitis, we have to start combination of intranasal corticosteroids and montelukast. But having said that, when you give the management, you should give a full course. giving about 2 days or 3 days or 10 days of INCS and Montelukast will not work because
Yes.
receptors have to come down. So you have to give fair chance for medicine
Yeah,
to
as a
work.
pediatrician, most of us we give a short-term therapy,
Yes.
and for 1 week, 10 days, we stop with that, and again the babies get aggravated symptoms, and we need to just go ahead again.
Yes, sir. We have to give full course.
Yeah,
But having said that, we have to keep monitoring the child in between.
Yes.
You can't say you come back after 3 months.
Yes. If the patients are symptomatic, definitely they come back. The
Definitely,
mild
yes.
symptoms, it was ignored by the parents, and once they get a major thing and aggravations, they land to us again what to do next. That's
Yes, yes.
If the patient is not having any adenoids or tonsils, only allergic rhinitis and snoring, what will we do? So we don't want to just label them as OSAA, or still there is a chance.
So there is a chance, sir. Like how Dr. Vijay said, the nose contributes to 50% of airway resistance, whether it's a
Yes.
child or it's an adult. So that allergic rhinitis causing significant blockage in terms of turbinate hypertrophy or an already mild septal deviation causing, now that suddenly becomes important. See, a mild septal deviation would have been there, but because of the allergic rhinitis, which has caused the edema of the mucosa, now becomes significant to the child. So you can always try conservative management. These children do brilliantly well. If we fail medical management, then you will have to evaluate before you put the child under the knife.
Okay, definitely, sir. Thank you. To Dr. Roshan, Dr. Ankita has put a question. How expanding the maxilla opens the posterior airway?
Actually, it actually enhances the nasal floor only. Okay, for posterior airway, it only increases the oxygen saturation basically. Okay.
Okay.
Posterior airway as such doesn't expand. Okay. The soft tissue expansion to a certain extent secondarily happens, but the primarily is the skeletal expansion which is causing the improvement in the oxygen saturation. Okay. So whatever certain done, if there is any soft tissue abnormalities, those soft tissue abnormalities has to be taken care by the ENT perspective, from an ENT perspective.
As you said, expand the maxilla laterally, that reduces the nasal resistance by increasing the nasal flow.
Yeah.
And if I'm allowed to add, now the benefits of expanding the posterior maxilla just does not end up with the posterior airway space as most dentists see it. It actually expands the entire pharynx. Me and Vijay, we've done a lot of study in this, and we know what we call as palatal phenotypes, so what is happening at the level of the posterior hard palate actually flows into the size of the soft palate and the size of the lateral pharyngeal wall. So it is a snowballing effect or a domino effect that this increasing the posterior space, posterior part of the nasal airway. So it's a phenomenal thing. You should do that.
Thank you. Just to Dr. Vijay, one question about immunity. How immunity will help in this? And there are a lot of questions regarding is the powder, the Proham is definitely going to help during the COVID. So the Sun Pharma persons can answer, and doctor can just add up to this.
So the role of immunity in adenoids and tonsil is important in pediatric age group, as we all know, till other lymphoid organs take over. But after that period of 10 to 12 years, the role of immunity by the adenoids and tonsil is very questionable. And definitely other much more organs are there to take over. But if it is causing a problem like obstruction, and if it is infected, and if it is causing a recurrent infection, no point in having that infected. It's like a watchman who is a theft. So having a watchman who has become a thief, and you are keeping them with you just because he is known for you for many years and he is doing a lot of work, that doesn't serve the purpose. So if the organ which is not going to serve its purpose, and if it is going to cause a lot of damage to your tissue, then it is better to get it removed than keeping it. So similarly, the role of immunity by adenoids and tonsil is definitely there. But if it is going to cause other issues like an obstruction or a recurrent infection, it is safer and better to remove it rather than suffering it with that. As Dr. Roshan clearly said, prevention is very important, and treating at the early stage of the problem starts, like 6 to 7 years. Once you miss that age group, then I think he has clearly explained how the malformations and dental patterns changes and causes a permanent, sometimes even irreversible damage, or may need many morbid procedures needed in future to correct all those issues, which is preventable and treatable if you diagnose at an early stage.
Thank you, sir. Sun Pharma persons,
Yeah.
is there anything about the immunity just related to COVID with your powder? Doctors has asked.
Yeah, actually being a very, very scientific session, and actually I don't want to explain my product. Though we are dealing with a new brand which is recently has been introduced, that is Prohance Junior, which is an all-round nutritional pharma for growing children. But this is not the right platform to discuss about the drug. So let me confine with this. So our representatives will come and meet all the pediatricians. I mean, definitely it has got a role.
Is there any link between COVID and your powder? That's they want to just clear.
I mean, I cannot give a concrete answer on this.
It's a general immunity and a protein supplement you are just going to give. That's all. Yeah, that's good.
Spreading a wrong claim, and then I will be questioned later.
Yeah, that's good. One thing to Dr. Srinivas. Dr. Srinivas, is there any indication or need for CPAP for pediatric patients less than 10 years? For adult, we commonly use for OSAA because after 65, you are not going to touch anything.
Yes.
Mostly a supplemental thing or some mechanical thing may work. Is there any role or need for pediatric patients with a CPAP?
There's an absolute niche area for the role of CPAP. Why are we even discussing this? The reason we are discussing this is because there are lots of syndromic children out there. Children with hypoventilation, children with, as you know, the FOX2 gene. All these children, they are there at home, the parents are taking care of them, but they all have significant amount of hypoventilation, which is increased CO2 in the body, to the extent that it will be about 55-60. So in order to take care of this, we need to put these children on CPAP, because these children don't fight like the regular children. So any syndromic children with a CNS involvement, central sleep apnea children, it is very important that you can put these children. Even 2 to 3 hours of CPAP use is very beneficial for these children, for their milestone to increase and their global development. But unfortunately, the acceptance is poor in regular non-syndromic children.
Okay. Thank you, sir. Thanks for the insight. Dr. Vijay, I'm just, as a pediatrician, I have a common question just that may be in mind of all the pediatrician. Okay. I'm just coming across obese pediatric children, and I'm not seeing any tonsils. Okay. So I may suspect an adenoid. So, and the baby is with a complaint of lot of snoring during night. Okay. And he has a poor scholastic performance also. How to proceed? Whether I need to just go ahead with the adenoid evaluation with an X-ray, or I need to just go ahead. Just give a proper idea so that how to evaluate with the obese children with the snoring, and he has little bit of dullness or hyperactiveness.
Yeah, it is a classical type 2 OSAS, what I was describing, with less adenoid lymphoid hypertrophy with obese children. So definitely we have to look in for the cause for obesity, whether there is any hormonal assessment has to be done, whether there is any obstructive component is there. Most likely these children will be having grade 2 adenotonsillar hypertrophy, just for their appropriate for their age. And we don't have to intervene surgically if it is grade 2. And we have to, if there is any other associated allergic rhinitis, we may have to address it with medication. Definitely the child will need a obesity management, weight reduction and exercise. If we don't find any other reason for, that means hormonal reason or any other pathological reason for obesity, we have to put them on strict weight reduction program definitely these children will be having, it is a vicious cycle. So as I told you, obesity causes OSA and OSA causes obesity. So if we do a PSG and see whether there is any severe OSA, then the child even may mandibular advancement device or a CPAP temporarily, so that the child will get enough oxygen saturation so that the child can work out. If you're going to whip a tired horse, like the child is already very tired because of low oxygen saturation, and asking them to do a lot of exercise and weight reduction program, the child may not cooperate because of poor oxygen saturation and hypercapnia. The child will be very irritable, and the obese children may not be hyperactive. They'll be very tired and sleepy, as clearly explained by Pickwickian syndrome. So that hypoventilation and the desaturation has to be looked for and can be treated with a CPAP or a mandibular device, whichever is comfortable for the child. And first correct the OSA or the hypoventilation, and then put the child on a weight reduction program. Definitely
Does
the
we
child.
put the child on polysomnography? We need to do it definitely, or we'll just go through the clinical thing.
So definitely.
We need to do for this child. Yeah.
At this point, I'd like to add one point here from a clinical perspective. The children with OSA or children with a narrow maxilla, what I've generally found is the behavior of the child. They are very, very anxious and fearful. And top of it, there is a very classical hyperactive gag reflex. They have a very hypersensitive gag reflex because the tongue movement is very much restricted. So when you touch the tongue, they feel very hyperactive and very lot of gag reflex is there in these kind of patients. And so they are very anxious and fearful when we want to handle them in the dental chair. So that point I'd like to add on.
Thank you, Dr. Roshan. And Dr. Srinivas, one last question. I think we can finish up the session. Okay, I'm just suspecting an adenoid enlargement for my baby. Okay, for my baby, what I'm following through. The parents are not willing for adenodectomy even after seeing the ENT surgeon. How long I can just continue with the nasal corticosteroids or the drugs, and how we just insist on the importance of adenodectomy that can just help the child. So just for the parents to convince them, what can we all add up?
So, sir, basically, it is a journey. So we'll have to start with conservative management. We can't just leave it. Now, adenoid is, after all, a lymphoid tissue. It will definitely respond to steroid. There is no doubt about it.
How much is the shrinking of that happens with the corticosteroids?
So there are two, yes. So what happens is, again, depending upon the age. So the younger the child, the better the outcome in terms of INCS, intranasal corticosteroids. But at the same time, in the younger age group, you can't use budesonide. Obviously, it is not allowed. The only thing that you can use is fluticasone furoate or mometasone.
Yes.
That is after 2 years. Now, below 2 years, if the child is having significant obstruction, and it will be clearly seen by the parent that there is because the airway is so small, there is a significant impact on the child, which is showing.
What age is the probable adenoid enlargement occurs, sir?
So it starts enlarging right from 6 to 8 months onwards.
Okay. And
you can't attribute it to allergy because allergy does not present such early in life. So this is a pure adenoid hypertrophy. And assuming this is a non-syndromic child, you can continue for at least 3 months of any of these medication. But you have to be careful that the prescribed drug has to be given. Just because a person is getting good response, you cannot give a very strong, put the child on prednisolone or something like that, because that will have very bad repercussions. Just because it is reducing, you can't do it. You need to use a drug that is approved for that age group. Keep monitoring the child, like how Roshan beautifully said, it's all about the risk benefit. And
yes,
try and see if the child is improving. If the child is not improving and we are hitting a wall in terms of prognosis, it is better to bite the bullet and do
I think growth chart will help us. Most of the pediatricians need the growth chart. If you are speaking to the parents, definitely that will clinch a proper thing. So most of the parents are in a clear view what the child is going to face in the near future.
Very so sentimental about the growth chart. They keep showing us also the growth chart. So
I think some amount of fear or something else
Yes.
will insist them to have a better management,
Yes.
acceptance,
Yes.
and other thing.
Yes. So,
It's a
the
good thing, sir.
owner, so the onus is on us. It is up to us to educate them. They don't know.
Yeah, as you said, that is a good idea. We just give lot of videos, so that will have an
Yes.
idea. So what the child is doing, it they can just watch when the child is
Yes.
sleeping. So that
Exactly.
will make the child parent to understand. Definitely, my child is suffering because of some issues which is happening with the OSAA. So definitely.
Yes.
For
Yes.
adults, they ignore whatever it may
They
be. For
ignore.
pediatric,
They
we need
ignore.
to just go ahead.
Yes. Yes.
Thank you,
Yes.
sir.
Thank you.
Thanks a lot.
Thank
It
you.
was a wonderful
have,
day.
Dr.
We
Vijay
just had a
Kumar,
lot of 2 hours of full packed educational session for pediatricians. That is a good thing. Tell me, sir. Yes.
Dr. Vijay Kumar, I have a question. As a common
Yeah, tell
time.
me, sir.
Yeah, I mean, what are the early symptoms or warning signs for OSA in pediatric? I mean, is there anything like that? Any early warning signs?
Early signs, it's not. Only it start with the snoring. First, as a snoring, we can't just think everything as OSA initially. So we need to just go with the common things. Okay, if it is with the upper respiratory infection or lower respiratory infection or allergic rhinitis, the common things has to be ruled out. If it is a prolonged snoring, the baby is going to have some more issues. Then we need to evaluate. It's not the early thing. We can just go ahead. Dr. Vijay can add on to this.
That's what Shivan started with the snoring sound in the initial.
Yeah.
So 3 days, 3 nights per week is considered significant. In a week, if the child snores for at least 3 days, it is quite significant. And as he said, the acute reasons like a child having an upper respiratory tract infection, a child is snoring, that is okay. That can be, once the respiratory tract infection settles, the snoring also will settle. But as you rightly asked, the initial symptom will be a persistent snoring and a sleep disturbance. The child will be restless, they will be upside down, their head will be on the east when they sleep, when they get up, it will be on the west. So they will rotate around the bed and the bed may not
That
be
is there with all the babies, sir. We can't just think of it. Most of the babies nowadays do like that anyway. Even our kid, we need to suspect like that.
Yeah, one more question to the panel. Do you suggest any sleeping posture to avoid this snoring or airway obstruction?
Not specifically in child age group. For an adult, we recommend positional therapy, everything.
Is it a prone position avoids sleep apnea, sir, because the tongue falling backward for obese children at least?
Yeah, it could be even side lateral is also good enough.
Okay, sir.
I would prefer a lateral position actually, because the common anti-snoring devices, whatever extra devices we give, sometimes when they wear and they are in a prone position, they find it very difficult. So in a lateral position with a pillow on the right and left side will be a very good position for the child to sleep during the initial stages of the appliance wear, and for a OSA child, they feel more comfortable. A lateral position will be best choice.
Rightly said, in few minutes they will be upside down.
We need to suspect a lot for our children too.
Yeah, true.
Thank you. Thank you, sir. It's a
Thank you
wonderful
very
thing.
much. It was,
I thank all the speakers for a thing, and Sun Pharma for the wonderful thing. Thank you, sir.
Thank you very much.
On behalf of Sun Pharma, my heartiest thanks to all the eminent speakers, Dr. Vijay Krishnan, Dr. Srinivas Kishore, and of course Dr. Vijay Kumar, who has made this session very lively. So, and thanks to all, thanks to all the participants. Thank you very much, and we'll keep continuing our academic services to the medical fraternity. Thank you.
Thank you very much.